So it is my pleasure to introduce Dr. Luciana Catanese, who is an associate professor of neurology at McMaster University. She is a vascular neurologist at Hamilton Health Sciences. She is our physician lead for hyperacute stroke care services at Hamilton Health Sciences, but also our hyperacute lead for our Central South Regional Stroke Network. She is the director of our acute stroke unit at the Hamilton General Hospital and is the director of the Stroke Fellowship Program at McMaster University. Dr. Catanese completed her stroke training at Harvard Medical School and has been actively involved in testing many novel therapies in acute ischemic stroke patients. She has a keen interest in evaluating the impact of CT perfusion implementation on systems of care in the expanded window. Her research interests include acute hyperacute treatments and acute stroke systems of care. So I'll turn it over to Dr. Catanese, who will provide our hyperacute stroke best practices, what you need to know.
Thank you very much, Rhonda, for that kind introduction. It's such a pleasure to be here today. Thank you very much for the invitation. I love this topic, so I'm always very, very excited to talk about it. And today share with you the new updates and best practice recommendations for 2023. So I'm gonna start by showing you an outline of the lecture. I mainly have been asked to talk about pretty much the hot topic in acute stroke these days, tenecteplase for acute stroke. We're gonna talk about tenecteplase in general, the ACT trial that many of you have heard about, what it shows and what it means, how those results impact our care, the care for acute stroke patients, especially here in Canada. And I'm going to outline and share with you the new TNK-related acute stroke workflow that we have created at our institution, and it's something that I foresee expanding and sort of spreading to the other institutions as people move over to TNK. I then will be discussing some of the 2022 Canadian hyperacute stroke best practice recommendations. I will be highlighting what's new and everything that is more focused on hyperacute stroke. There are some things in secondary stroke prevention I will be leaving aside. But again, as Rhonda has mentioned, I'm always happy to take questions at any point in time. So please feel free to post them in the Q&A section, and I'll be addressing them as I move along. So let's get started. I first want to share a poll with the audience to see where we're at. And the question is this: how comfortable do you feel using tenecteplase in acute stroke currently? Do you feel very comfortable, but still have some doubts, neutral, uncomfortable, but you're open to using it in your practice, or you wouldn't use it? So go ahead and just share your thoughts. It's completely anonymous. We'll give you a few seconds, and then let's take a look. I'm imagining many people here come from different sites, so it will be interesting to see where we're at.
Okay. We have about 60% of people that have participated, so hopefully just we'll give another few seconds.
This audience is the fastest. Amazing. Yeah.
Okay. I'm going to end the poll now, and then I will show the results.
Excellent. All right. Oh, I love these. 43%, so the majority of people in this webinar feel neutral about it. So that gives me an opportunity to share my thoughts with you, see if you change your mind. The good thing, nobody said I won't use it, so that's good to be open and to see whether this fits your workloads and needs for your site. 21% felt comfortable, and another 21% felt comfortable but had some doubts, and a minority felt uncomfortable, but they're open to use it. So also I hope that we can clarify some doubts related to the use of TNK compared to alteplase. So let's move forward. Just to give a background, I'm sure everybody here knows, but just to highlight here the differences between TAPA and TNK. Just as a disclosure, TNK is also a TPA. It's also a tissue plasminogen activator, but we call it TNK just to simplify matters. But just for you to know, both, they sort of do the same thing. So in a natural environment, the endogenous TPA will release them from the endothelium in the presence of a thrombus, and that tissue plasminogen activator binds mostly to the plasminogen that is bound to fibrin and activates that plasminogen in plasmin, who's the one, this protein here, is the one that will degrade the fibrin, that it holds that clot together and will disrupt that fibrin so it can release those red blood cells into the bloodstream again. And it creates these products called fibrin degradation products. And these products, they will sort of feed back and activate more plasminogen into plasmin, because that means that you have a thrombus and that the system needs to be in thrombolysis mode. So the thing is, when we administer exogenous tissue plasminogen activator, known as alteplase, which is the most common thrombolytic that we're using these days, what we do is we overwhelm the system. We administer excessive amounts of TPA. And I should mention that the TPA gets inhibited by this protein called plasminogen activator inhibitor. There are two types, and this is sort of downregulates the thrombolysis cascade. What I do is to overwhelm this system. I overwhelm the capacity of plasminogen activator inhibitor to inhibit that system, and I cause an excessive thrombolysis on purpose. The idea is that excessive thrombolysis will lyse quickly that thrombus that is not supposed to be there. Now, one consideration with alteplase in general is that it will bind to plasminogen that is not attached to fibrin, okay? So that's when we see that we look at studies that measure plasminogen levels after thrombolysis is infused, and we see that there is almost a 50% depletion of plasminogen in bloodstream. So it generates a coagulopathy associated with TPA. But TNK, and I'll show you why, is a lot more specific to that plasminogen that is bound to fibrin. So it's a plasminogen that is attached to that clot. The clot is the one that has fibrin. So it makes it a lot more specific, with less so of a chance to cause this systemic coagulopathy we all sort of fear. So what it is a protease, and enhances the conversion of inactive plasminogen to active plasmin. At the end of the day, the one that does the work is the plasmin. It's not the TNK or the TPA, it's the plasmin, but we need to activate as much as we can in this setting. And that's how this plasmin is dissolving clots, and we call it a clot busting medication. So let's look a little bit more about the differences. This is a very nice paper with a lot of beautiful graphs that I use in my presentation. If anyone wants to access to it, this is a reference. Here we have on the left-hand side the molecule of TPA, and on the right-hand side the molecule of TNK. And what is TNK? As I'm showing you here in this big message here, TNK is a genetically modified version of TPA. So it's still TPA, but it's genetically modified. And where is it modified? Well, it's modified in the T, in the N, and the K amino acids of this protein. And that's why it's called TNK TPA. What do they do, these modifications? Well, the T and the N provide them with a longer half-life. And how can a molecule survive more in this case? Well, it's more resistant to that plasminogen activator inhibitor. It's like 80 times more resistance indeed. It's quite a lot more resistant. And the K mutation here on the amino acid also leads to the 80-fold resistance in TNK compared to TPA, and it provides it with a bit of a higher potency and fibrin specificity, which is the other characteristic of TNK. It's very specific to fibrin-bound plasminogen, which is wonderful. Now, let's take a look here comparing what that means. Well, what does that mean? First of all, the obvious is that one has a very short half-life compared to the other, 4 minutes versus 20. That's a 5 times higher, longer half-life. And that's because it's more resistant, you can see here, to has an intermediate resistance to PAI, so plasminogen activator inhibitor. So if you are more resistant, you get degraded less and you last longer. The other thing is that it's more specific to fibrin. So TPA is actually has an intermediate specificity, acts also in systemic plasminogen, which is not ideal, but this one acts primarily on the thrombus and is 14 times more specific. It causes fibrinogen depletion at a very low rate. It's about 10 to 15% versus about 40% or 50% actually with TPA. And as you can see here, because of the aspects of TPA that I've mentioned, you can find actually a small coagulopathy when you test for these after patients get TPA. Within 24 hours is the most common, but it can even be longer than that. So theoretically, the benefit, TNK has a benefit in recanalization and bleeding risk over TPA. And that's why it became a very interesting thrombolytic agent. So the one thing I wanted to mention with this slide is that those characteristics of these molecules they lead to a very important fact. And the fact is that one alteplase needs to be administered in an infusion for 60 whole minutes because of the short half-life. And the other, TNK, can be administered as a single IV push, a bolus, given within 5 to 10 seconds. So we have faster treatments without the need of a pump. And you can think about what that could mean, like less error dosing, more effective or efficacy, more effective or faster delivery of thrombolytic agents. The only downside, if any, if it is a downside, and I'll show you the data in real life, is the inability to stop it if the patient deteriorates or if information becomes available. Okay, we'll give TPA and then we see platelets are 50 or 20 and we stop it. Well, that is not possible with TNK. Those are very rare situations though. So what has happened throughout the history? I like to show these to put things in perspective because this is a TNK. This is a timeline of the first landmark trials in MI and stroke. And you can see here, we have a TNK actually became available as a molecule in 1994, but it wasn't until 2000, after this flurry of trials, the TIMIs and the ASCEND trials in cardiology, that it became available for the use of a STEMI in cardiology. But it took us about 22 more years to get there. And the reason is the risk of bleeding, is the safety. The safety has been one of the main things. So what happened is after it got approved for MI, we have a flurry of trials in stroke, escalation, dose escalation studies, also trials, phase 2 studies looking at safety, and finally 2 phase 3 studies, non-inferiority trials that now cleared the picture, not fully, but certainly enough for us to be able to use it in acute stroke. So one of the landmark trials is, if not the landmark trial, is the ACT trial. So the ACT trial is an actual, it's a local trial. It's a Canadian trial. that enrolled is a phase 3 non-inferiority trial that enrolled 1,600 patients in Canada. We enroll about 56 at Hamilton General Hospital. That looked at efficacy and safety of TNK compared to TPA, given within the standard of care for thrombolysis. So patients that presented within 4.5 hours and met the criteria that we are very aware of. They studied the TNK dose at 0.25 milligrams per kilogram, and that's the one that we have most evidence on safety and efficacy. And what they saw, to make it simple, is that TNK was non-inferior to TPA in the proportion of patients who achieve independent outcomes as well as safety. So you can see here that in terms of efficacy, how good this medication is no worse or no better than TPA, or not inferior, I should say. About 36.9, 35% of patients achieve these outcomes, very standard compared to the trials that we've seen in the past. And in terms of safety, actually, it's nice to see that the rates of symptomatic ICH did not differ between drugs, and they are around 3%. This is lower than the initial 6% risk of symptomatic ICH that we've seen in some of the previous trials in thrombolysis. Again, reassuring, there was no difference in mortality. It was literally the same, around 15% in each group, which is actually, again, on the lower side. And I should mention again, this is a Canadian-led study. So the first positive non-inferiority trial for TNK compared to alteplase is from Canada. So that should make us all very, very proud. So bottom line, what we learn here from Dr. Menon's trial, that intravenous TNK at a dose of 0.25 milligrams per kilogram is a reasonable alternative to alteplase for all patients presented with acute ischemic stroke who meet standard criteria for thrombolysis. So that patient you give alteplase, you can also give tenecteplase, or you could choose to do that. This translated quickly on the to the Canadian stroke best practice guidelines that were published in 2022. And they added a new recommendation that is worded as such. Again, tenecteplase may be considered as an alternative to alteplase within 4.5 hours of acute stroke symptom onset. This is a strong recommendation with moderate quality of evidence. And why is that? Because there's only one randomized trial showing non-inferiority. It hasn't been, we don't have more data as of yet, or other randomized trials. So they recommend that if you administer TNK, you do it at a dose of 0.25 milligrams per kilogram, up to a maximum dose of 25 milligrams, given as a bolus over 5 seconds. Remember, this is not the same dose as that administered for myocardial infarction of massive pulmonary embolism, because the one for myocardial infarction is 50 milligrams, is twice the dose. So this is a very, 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 very important thing. They also went a step further and added that health systems leaders should work with hospitals to coordinate plans for launching tenecteplase and consider group purchase opportunities. Health Canada should undertake rapid review and approval for use of tenecteplase in acute ischemic stroke. And that is something that hopefully we will see coming along, hopefully this year. So what are the implications for us, for the Canadian stroke landscape? This is our beautiful landscape here in Hamilton, by the way, the Webster Falls, one of the many, many falls we have here around Hamilton. So that means that several centers around the country have already switched over to TNK as a thrombolytic of choice for acute stroke. It also means that the company that makes tenecteplase has been contacted and has confirmed that they can provide and have enough supply to deliver TNK to all institutions, if that's what the rest of the Canadian stroke community wanted to do. And then Health Canada approval is being evaluated. There is just a recent trial that finished called Timeless that gave tenecteplase. We were also part of that study. Up to 24 hours in patients that have positive mismatch, and that if it is positive, would also be part of this application. So we will be hearing about soon. That also will have significant impacts if it is positive, but maybe for another webinar. So let me tell you, why would you switch? Why would you switch? Why bother, right? Why going through all of these if it is non-inferior, if I can use either one of those? Well, this is a rationale for switching over from alteplase to tenecteplase. One, I think the main thing that prompts this is the ease in administration over alteplase. So the ease in administration is very, very likely to, and we already see it, and we actually saw it during the ACT trial itself, that it has a positive impact on nurses and ED staff in general and patients. There is less room for dosing errors without the pump. It can increase efficiency, so faster treatments, and potential positive impact on interhospital transfers times, hopefully. We'll still have to see that. But hypothetically, something that is administered within seconds versus an hour could actually allow us to expedite our workflow. There is a marginally monetary gain, as there is no need for specialized pumps or tubing, and potentially gives more flexibility to give it in other areas, for example, the radiology suite, to cut down door-to-needle times. So it is actually something the ACT trial committee is talking about, that perhaps as we use it more and more, we'll see actually a decrease in the door-to-needle times as people become more used and more comfortable with the delivery of TNK, because it's just so fast. Others to consider, it may be superior to alteplase in patients with large vessel occlusion. This comes from the Extend-IA trial that show that it has 50% more recanalization rates when administered within 4.5 hours. TNK over alteplase, again, is a radiographic outcome, so it has to be reproduced. But also these patients have better functional outcomes in that study with large vessel occlusions. For those that have mobile stroke units, it can be given in an ambulance, and it's faster and better than alteplase, as shown in the TASTE-A trial. And is hypothetically, and actually there's many publications about this, I shouldn't say hypothetically, that is more practical, has better sort of infectious disease control done during the pandemic times. A lot of centers around the world switch over to TNK in hyperacute ischemic stroke because of the decreasing contact with patient required, because the pump is no longer a thing that needs to be managed. So let me tell you a little bit about our processes. So we thought about, once the ACT trial became positive, we have been participating in it, we had used it. We had very, very good feedback from the emergency department nurses. They actually didn't want to use alteplase in many times. So we thought about, we elaborated a plan to implement these at Hamilton General Hospital with the objective to switch over from alteplase to TNK fully. We went live actually a few days ago. And these are several things that, some of the things, not all, but some of the things, the most important things that took place and that should be considered when implementing new thrombolytic agents such as TNK. First of all, the first step was to ensure adequate supply with a company that was contacted, not only in the emergency department and other areas that are administered. Remember, this is used for STEMI and massive pulmonary embolism and cardiac arrest. So it has to be available for those indications as well. So we didn't want to deplete it. So that's the first step. Number two, probably each one of the institutions has to apply to Pharmacy and Therapeutics Committee to add stroke as an indication in the formulary for TNK. Again, is only indicated approved for STEMI and massive PE in cardiac arrest setting. Then we created new order sets that reflected mostly the correct dosing and administration of TNK. The dosing is everything because it's used for other indications. People are very accustomed to using them in higher doses. So that's the main threat to safety with the transition of TNK. So I'll spend quite a bit of time talking about dosing. Education, of course, to all parties involved is always part of changing process. We outlined directives for the parties involved in the administration of the drug. The dynamics are different than just programming a pump, for example, at least at our institution. We acquire 5 ml syringes for our emergency department, and I'll explain why. And we just put tire-based dosing charts in the ED. This is how it was done in the ACT trial. They had tire-based dosing charts, and I'll show you those as well. So let's start with, okay, you identify a patient who's a candidate for TNK, and you say, okay, let's mix it. So there's 2 steps. One is reconstitution of alteplase, and the other one is the administration. And it's important to outline who's going to do who. The less uncertainty, the faster things go in a hyperacute stroke setting, and generally in any single process that requires speed. So in our case, the reconstitution of tenecteplase is done by the nurse. So they obtain that from the Omnicell, they reconstituted, which essentially is using a 10 ml syringe to draw sterile water from one vial and put it to the other, which has the powder, like very much in the same fashion of alteplase. You swirl them, you don't shake, and then the nurse will draw the correct dose in a 5 ml syringe, in a small syringe, in a 5 ml syringe, and hand it to the physician. So in terms of the administration, the first step is to double check the dose. So double check the dose with the dosage chart available in the emergency department. And then once it's checked and is confirmed, then the stroke neurologist pushes the bolus of TNK and flashes the line with 20 ml of normal saline. Thank you, Rhonda, for adding that. You raise your hand. Go ahead.
I just was going to add, Dr. Catanese,
Yes.
it doesn't have to be the physician that does it, which you probably were going to get to, but it could be anyone who has that knowledge and skill to do it. So I know in some centers, it's the nurse that is administering the bolus.
Yes, excellent point. So I put here in between brackets, could be the nurse practitioner, and many services do have nurse practitioners for acute stroke, or the trainees. In our case, trainees administer our fellows TNK. They had participated in the ACT trial. They're very, very comfortable with this. They're excellent. So it really depends on the institution. But we thought that this this is very standard, actually, when looking at other institutions, including Calgary, who are the ones that designed the ACT trial. Generally, it's the trainees that administer the drugs, or the stroke MD. So dosing is extremely important. I think, if anything, this is the place where it's worthwhile to stop and think. So the dose is 0.25 milligrams per kilogram. So the max dose is 25 milligrams or 5 mLs. And that's why we have a 5 ml syringe, because 5 mLs means if I fill up the syringe fully just by mistake, and I give it and I hand it to another person and they don't pick up the error, I'm not going to give more than the max dose. Not ideal, but it has happened within the ACT trial that there was used 10 ml syringes at that time we had, and the full syringe was filled, and that 10 ml syringe has 50 milligrams of TNK, and that was picked up by the physician, the stroke physician that was about to give it. So it's sort of something to keep in mind. 5 mL is the max dose. This is a tire-based chart that they use in the ACT trial and the ones that we are using, because ultimately we want to replicate the outcomes that were in the trial. So you can see here that based on the weight, there is sort of a 10 kilo weight range here, where you can see they round up the dose to either in 0.5 intervals. So 3, 3.5, 4, 4.5. This is taken from cardiology literature. This is how the cardiologists do it. So, you know, the importance, I think, is, of course, it has been tested in a randomized trial, so it's quite safe to say that we can definitely use the same charting dose. Now, just to point, just one thing for you to know is that patients that were 40 kilos or less were not included in the ACT trial, okay? So we don't know if these 3 mLs are, you know, safe. The other thing is that, you know, generally you go to greater than or equal than 60 to less than 70. So 60 to 69, right? 70 to 79, 80 to 89. So less than 60, it could be 50, it could be 45, it could be more than 9 kilos or 10 kilos. So the question is, should we be administering 3 mLs to anyone else below that weight? So we call them in the very low weight tier. So that's the question. And interestingly, we had the first case that tested our knowledge. This is how things work in real life. First case was a 98-year-old female from a nursing home who presented with right-sided weakness and aphasia 2 hours into symptoms. She had an IH of 7, no contraindications for TPA or alteplase or TPA in general, thrombolysis. Her weight was 50, was less than 60. So according to our chart, if I may go back, if it lets me, yes. So 50 kilos will be less than 60, and she will be given or administer a dose of 3 mLs. But the team quickly recognized that 3 mLs for someone that is 50 kilos would be a dose of 0.3 milligrams per kilogram rather than 0.25 milligrams per kilogram, so slightly higher. So what they decided to do is to calculate the actual weight-based dose, which was 2.5 milligrams. And they decided to do that to enhance safety. And I explained why that was a thing. And there were no safety issues, of course, in this case. But let me show you why. So remember I saw you, there was 2 phase 3 trials that were published, ACT and NORTEST. They were published pretty much at the same time. NORTEST 2 is actually a very important study when talking about TNK. It's a phase 3 randomized non-inferiority trial that was conducted in Norway. And it randomized acute ischemic stroke patients within 4.5 hours that were candidates for thrombolysis. They randomized 1-to-1 to alteplase versus TNK at the dose of 0.4 milligrams per kilogram. What they look is that they looked at mainly safety of this, but mostly non-inferiority in terms of, safety and efficacy. What they showed is that they actually had to stop the trial early because of an excess risk of symptomatic ICH in the patients receiving TNK at a dose of 0.4 milligrams per kilogram. Not only led to higher ICH rates, but also worse outcomes than TPA. So this is something we don't want to do. So now we have clear sort of guidance on this higher dosing. Initially, there was a trial that did show that it was effective for patients with large vessel occlusions, but again, now I think everybody will hope to stay away from this dose and stick to the 0.25 milligrams per kilo as much as possible. Go ahead, Rhonda.
Okay,
Go ahead.
There were a couple of questions in the
Yes.
chat, so I just wanted to check it. The question came, can a physician assistant administer tenecteplase?
I think it really depends on your local processes. I don't think it's more difficult to administer TNK than any other IV push in terms of logistics. So the main thing is to be able to double check, I think, the correct dosing. And then the actual administration is actually very easy, very, very easy.
And then there's another question is, when the timeless trial is reported, is the hope that T&K will be able to given by the nurse?
Again, I think nobody mandates or nobody has any evidence on who should be given this. I think for our institution, the thought is that this is how we want to make sure that we enhance safety as much as possible based on our workflows. Also, the nurses are likely to learn a little bit about dosing. There is a difference between what they always do with T&K than what they are doing with stroke. Maybe just we're overly cautious. But there had been incidents, so we ran the ACT trial and we have picked up one was a near miss. So that's why we wanted to just be able to have the trainees administer it or the stroke physician. But if you have a nurse, I think it's reasonable.
Yeah, I know at some of our centers, because it is within the scope, and I know one of my colleagues in Kingston is nursing are administering it. It could be either or. So I think to your point, Dr. Catanese, I think what makes sense in your institution, and if it's within their scope and knowledge skill to do it, I think is reasonable for sites. There's one more question is, do we need to give any adjustment for renal function to dosage?
No adjustment for renal function. In general, patients with CKD will have a higher, there is conflicting data on this. There are studies that don't show a higher risk of bleeding, others that do show a higher risk of bleeding. Depends on how bad the CKD is, but these thrombolytic agents are not cleared renally, so they don't need to be adjusted for renal function. Okay, fantastic. So we modified these based on the Nortes trial and the possibility of having patients in the very low weight category. We modified the table, added 2 more tires, obviously knowing that this is not based on randomized data, but it's more in line or more, yes, it's more in line with the 0.25 mg per kilogram that has been used. And for patients that are less than 40, we actually recommend that it's purely weight-based calculation in this case, because there is no data that we should be using tires. In general, they have not been enrolled in trials, so I think that will make more sense to ensure they are closer to the 0.25 mg per kilogram as possible. Now, talking about being close to 0.25 and giving 3.5 mLs, well, that's not easy. Actually, one of the things that we are exploring now in the ACT trial is differences in and errors in administration. Remember, this trial has many sites that did not check a specific weight on patients, so they didn't check the actual weight. They went by suspected or estimated weight visually. So there are going to be some differences in what the patient really received and what the dose was for them. So these are the 2 syringes that generally, the syringe is generally available in emergency departments, a 10 ml syringe. As I mentioned, the downside to that, they both go the 5 ml, I'm showing you here the 10 ml and the 5 ml. They both go on 0.2 ml increments, not on 0.1, on 0.2. So it's hard to do 3.5 even, but it's the closest you can get. And the one downside for the 10 ml syringe, the good side is that it's available. You don't have to worry about it. It's always going to be available. The downside is that it has a higher risk for overdosing, because if you fill it up all the way, you're going to be given the max dose you're going to be giving 10 milligrams, 50 milligrams, which is the dose for STEMI, not for stroke. For stroke is 5 mL, the max dose, right? It's 25 milligrams. The good thing about the 5 mL range is that minimizes the risk of overdosing, because even if you fill up to the top, it's still the max dose within stroke, and what we know in terms of symptomatic ICH rates. However, the downside is, for example, in our institution, we don't have it. So we have to order specific syringes for this purpose. But we chose this. We chose to go with safety based on our own experience by running the trial. There are other syringes, the 3 mL, the 1 mL syringes, but we consider them not to be practical because, you know, you'll have to have a person that is 59 kilograms or less to be able to use them. Most people are above that. So not practical. Okay, let's talk about side effects. Generally, the concerns are related to side effects. What are the side effects from these? So I would say overall, forget about it. This is the same as alteplase. Nothing has changed. TNK is not more harmful, is as safe, is not, if not safer. So symptomatic ICH rates with alteplase, we see about 6%, right? With TNK, we have seen in the literature, there's a lot of literature now, the 0.25 mg per kilogram, we see about 3%, if not 2% of symptomatic ICH rates. Unfortunately, we haven't yet gotten the data on fatal ICH rates. I just asked to see if we have that data, but we don't have the data from the trial yet, but we will have it because families want to know, okay, of the people that have symptomatic ICH, what's the proportion that die, right? We don't have that data yet. So once we have it, we will share it. A 1% rate, there is a 1% risk of systemic bleeding, a 1% risk of angioedema. In the literature, is anywhere between 1 to 5%, or around 1% in ACT trial. So no differences in terms of side effects at all. So I want to know, after you've heard really the main things here, will you be switching to TNK in your facility? Let's post it up. See. And it's okay to be not sure. Still not sure. It's okay. It's not inferior. So go ahead and
just waiting
share
for
your thoughts.
Yeah, just waiting for a couple more people to respond.
All right. That's an easy one. 3 options. All right. Well, wow, nobody said no. Interesting. Good. So will you be switching to TNK? 74%, so the vast majority of the participants here today said that they will be switching to TNK in their facilities. So we're happy to help and share all of the resources that we have and our experience, which will be growing moving forward. And 26% actually said they are still not sure. And I would love to hear from these 5 participants that are not sure, to try to understand what are the questions that remain unanswered. It would be wonderful to hear. Again, TNK is not inferior to alteplase, so either one of the thrombolytic agents is good. All right, so quickly, I think I'm running out of time and I want to leave time for questions. We have 1 hour, right? Correct?
Yes.
Yes, 1 hour.
Okay. So I'll show you the most important things here. Canadian Stroke Best Practice Recommendation, the updates that I think you'll be interested in. Okay, so there are many updates. The alteplase ones I mentioned. There was also an addendum, and for the first time, our guidelines address the management of symptomatic ICH and provided new recommendations, most of which are actually of low quality. So we won't spend too much time there. Highlight what's important. They provided a very controversial recommendation on the combined use of IV and EVT versus direct to EVT approach. As everybody has heard, it's been a hot topic last year. There are some new clinical considerations, but not much of really that will change our management. And there is other sort of recommendations, not necessarily for the hyperacute stroke care. So I'll really fly through May, but virtual care in the emergency department has been addressed. And again, they are providing more specific recommendations on the use of telestroke in the emergency department, which is important for all the sites that use telestroke. Okay, management of ICH. I think everybody here knows that you should consider ICH when there is acute deterioration in the neurological status. Mostly you will see decreased level of consciousness with elevated blood pressure that is hard to treat, or a new headache. So once you have a suspicion that a patient is having an intracranial hemorrhage as a result of thrombolysis, the first thing to do is to discontinue the infusion. This is a strong recommendation with moderate quality of evidence. So this is something that should be done. Discontinue the IV infusion. Number two, what do I do with the blood pressure? This is something that comes up quite frequently. Okay, so the patient is having an acute stroke, and I know lowering the blood pressure can make them worse, but they're also bleeding. You should lower the blood pressure if it is above 185/110. You should lower the blood pressure. Again, above this target. However, the specific target and duration of therapy are unknown because overall we don't know how low we should lower the blood pressure in these patients, of course, but it should be lower below that threshold. The patient should go for an immediate stat CT. Again, strong recommendation with a moderate quality of evidence. And the one thing they add here, which is interesting because most sites will do a CT-CTA together, but if you haven't done a CTA and you have a patient that has decreased LOC and they don't have a bleed in the CT, they recommend you do a CTA urgently to identify intracranial occlusion or the need for urgent EVT. This is if you haven't done it before, because there is no value on someone who has an M1 occlusion and gets worse and doesn't have intracranial hemorrhage. It's obviously as the collapse of the collaterals, which we see very often. Now, blood work should include a CBC, INR, type and cross. And again, this is a strong recommendation, but low quality of evidence. But I think everybody would agree that it's quite standard of care to order those blood work. So just to make it easy, this is a graph. Again, I can share these slides, but just focus on this upper part. You suspect a bleed within 24 hours, stop thrombolytics, obviously ABC. First, they may need to be intubated in some cases, lower the BP below 180/105 and get a stat CT. Anything, and the labs I think are quite standard. Anything below this, all the potential reversal agents, they're not reversal agents, but all the potential agents that can treat the coagulopathy associated with thrombolysis are actually conditional recommendations of low quality. So this is where a case-by-case approach takes place. I would say if you have a fibrinogen depletion, you can give fibrinogen concentrate. Remember that thrombolytic agents will deplete fibrinogen, alteplase more than T and K, but if that's the case, then repleting fibrinogen is reasonable. Consider cryoprecipitate 10 units. We certainly do that if we don't have the fibrinogen concentrate. Avoid factor 7 activated, avoid giving factor 7, PCC and platelet transfusion, they can be harmful. And then tranexamic acid, again, is a consideration. Most of us will give tranexamic acid. Tranexamic acid is an inhibitor of the plasminogen activator and the plasmid activity. So it makes very good sense to give it. Some people worry about seizures at 1 gram bolus. I wouldn't be worried too much about that. Never seen it personally, and we give it when we have bleeds. Also works like wonders if you have any bleeding in the oral cavity as a gel. It works incredibly well. So blood pressure, send tests, and treat. And again, any treatment isn't mostly on a case-by-case basis, but try to avoid these products that can be harmful. What about combining intravenous thrombolysis and EVT versus going for EVT directly? Okay, simple. There's more than one randomized trial that showed that the The direct EVT approach is not non-inferior. Therefore, no conclusive evidence to support direct to EVT, period. IVT remains the standard of care in those patients that are eligible. So don't worry about this. This is not what we're doing. MAID, the most important thing that we get from the recommendations, which we saw coming, because this is something that patients are requested, is that physicians should be aware of this and understand what to do if they are asked about MAID, medical assistance in dying. Up to the point, we have actually our stroke nurse in the stroke unit who provides education about MAID and is one of the physicians or the providers that can deliver MAID medications. We have had cases in the stroke unit. Important to become familiarized with this if you don't know about it, because this is something the patients are requesting. So virtual acute stroke care recommendations. Most important to know is that it should be integrated into acute stroke care planning and delivery, just to ensure that we have equitable access to care across geographic regions in Canada. This is something we do within our network very well. It does create an equitable access. It should be in place, but also it should be readily available. The camera should be there, ready to go. When stroke expertise is not available on site, very, very important. This is now a strong recommendation with a moderate quality of evidence. Consulting and referring sites should have standardized protocols and processes in place to ensure the access to stroke experts through virtual healthcare modalities available 24 hours a day, 7 days a week to provide care. Consultants should be physicians with specialized training in acute stroke management and must have timely access to diagnostic quality neurovascular images, as well as any labs that are required. And it's important to see that we really need to make that effort to make those videos work because the benefits of telephone consultation are not well established. And every attempt should be made to connect via that video link. So it's important to keep those videos. It really does make a big difference as a telestroke neurologist myself to have that video available. All right, I'll stop there and see if anyone has any questions, or it was incredibly clear. And there are no other questions here.
Are there any questions for Dr. Catanese? You can either raise your hand, you can put them in the chat or put them in the Q&A.
If you would like to share some of the members here who had some questions still about TNK, it would be wonderful to share those with the audience.
So feedback, thanks for the excellent talk. Any
Thank you.
questions from the group?
And I put my email there. So if anyone prefers to email the question, then I'll be very happy to answer those. We have a question here. Yes.
Yeah, we do have a question. How soon after TNK do you start antiplatelet agents? Great question.
Yes, amazing. Thank you, Frank. So essentially everything else after the delivery of TNK is the same as TPA. So per standard is about 24 hours after a CT scan is done, and we ensure that there is no hemorrhagic transformation that will be that will make us hold that antiplatelet. But otherwise, anything else like monitoring post TNK, blood pressure post TNK, everything else is the same. Thank you, Frank, for that question. Oh, they are coming through the chat and the Q&A.
Yeah.
Excellent. And I think we'll have a lot more to share with you once we have more cases, because we always learn with each case. Well, we had the ACT trial, so I think we learned quite a bit already, but within a trial, this is always a little bit different.
Any other questions?
Oh, I still see that question. And if anyone wants the charting, the weight-based dosing, or any of those resources, we also have a pharmacy and therapeutics proposal. Yes, there's a lot of resources that could be used from by other sites.
Yeah, certainly I know
Very interesting.
Certainly I know with our key leads at our sites, I have shared a lot of the resources that we've developed, and certainly happy to and share some of our electronic order sets and pieces. So certainly any questions, any sort of resources, we are more than happy to share, but also to support what that looks like in your organization. Great question. Is there a potential plan for pre-hospital admission by paramedics with set protocols?
Yeah, that's amazing. I mean, this happens in other places in Canada through a mobile stroke unit. The caveat for that is without a mobile stroke unit, you don't have a capability to perform a CAT scan to ensure it's not an intracranial hemorrhage. Overall, we know from the data that we're not good at determining for certain which one it is. Sometimes we see patients, when we see patients, we don't know if it's ischemic or hemorrhagic. So yes, that CAT scan needs to happen, and it can only be done with a mobile stroke unit. But mobile stroke units, I hope that will become more available throughout Canada. It would be just so wonderful to have those.
And then there's a question of for inpatient code strokes is, can we have a weight chart in the medroom on the stroke unit? And so certainly I know on our stroke unit, we have an inpatient stroke thrombolysis binder resource. So certainly the weight-based dosing will be part of that. And we can also put it in our medication room. So that is in the works.
Yes, we in the ED, we have it as a sign there. So you have to look for it. It's there and we go look at it, done.
Yeah.
And that's how we had the TPA as well.
Any other questions for Dr. Catanese? Well, thank you so much, Dr. Catanese. It was such a clear presentation. You covered the material so well and made it so simple for everyone to go. And I think it's great because it really will help inform the implementation from certainly our other sites and certainly our regional team will be able to support that any sites with any of their resources or education or rolling this out. We will be, as the video is recorded, I will send the link out tomorrow with an evaluation form for your feedback. It will also be posted on our Central South Regional Stroke Network website. So it will be available for a resource to share with those who may not be able to attend or for those that have further questions. So thank you everyone so much for this great presentation. And thank you everyone for joining us this afternoon.